when I look at my title for this talk today is it's looking at life from both sides now. And you could guess that at one time I was a clinician and clinical researcher, and now I'm theoretically retired. And it's interesting as you go through a career like I did, a career in geriatric medicine, and it was very exciting because it was at the threshold of the evolution and development of the whole specialty of geriatric medicine in Canada and in other countries. And we also often talked about our geriatric patients, but you know, the reality is them are us. And that's where I am at the present time. I think I'm one of them. Some days. And Mitchell was a prominent folk singer when I was in my early stages of my career.
Tears and fears and feeling proud to say I love you right out loud. Dreams and schemes and circus crowds. I've looked at life that way.
The objectives of this a relatively brief presentation, because we have another presenter who's going to get into the nuts and bolts of exactly what we do about all of this. But the first thing I want to talk about is to identify the risk factors for dementia, which includes Alzheimer's disease and related disorders. And Daisy was wonderful in her presentation of the items, so this is going to be a bit of review. So it's repetition for understanding for all of us. And prevention broadly. And then I just want to take a little bit of time to review a couple of factors which could review risks, which could modify risks. As Daisy said, we have been working on trying to understand what the real risk factors for dementia, particularly Alzheimer's disease in Canada, and the Canadian Study of Health and Aging looked at that area. And one of the first situations that they talked about as a risk factor, I should say that we see relatives with dementia. The likelihood of you getting a dementia yourself is higher. Now, this is not a risk factor that you can do something about because we're born with the genetics that we have. But fewer years of education is certainly one that's included in the current ones. And the items that I've underlined here are the ones that are also occurring in the later enumeration of risk factors. In the Canadian Study of Health and Aging, they put coexisting conditions, which included peptic ulcer, migraine, but also depression and head injury or traumatic brain injury. And we'll see that appearing again. And we've already talked about antiperspirants, and at the time that we did the Canadian Study of Health and Aging, the total resolution of the roles of aluminum and so on hadn't been put down in a good way. Another item that came up was drinking tea, and there was two other factors, smoking and alcohol, which were included in the CSHA risk factor enumeration, and they're now in the current risk factor enumeration, which you'll see. And the other thing in the risk factor list from the CSHA was at least a difficult recovery from anesthetic, if not the anesthetic itself. And to me, that's one thing that needs some more work, and it hasn't been included. First published in 2017 are the ones, these 9 that Daisy enumerated, and I really want to underline the low social contact, because social contact is such a big issue for people as we all get older. And it's such an important thing that is being restricted for all of us now because we can't do all the social issues that we used to be able to do. Hearing impairment is in this list. And I can't tell you how many patients that I've seen when I was in clinical practice who had hearing aids, but they were in the drawer at home. The opportunity to attend an adult day center, which sometimes seniors have to pay extra money for, is something they don't want to spend money on. And the longest I've ever taken to convince a patient to go to an adult day center was 6 years. And 3 additional risk factors: the excessive alcohol consumption, traumatic brain injury, and air pollution. And we have just, well, we've got mist today, but we've just had the worst weather in the world through Vancouver, the lower mainland, I believe. And overall, I think these 12 risk factors altogether are the foci that we should look at for prevention. In other words, if we understand what are the risky factors, we can discover prevention. Now, there are 3 kinds of prevention. There's primary prevention, which is an intervention so that the illness or disability doesn't occur. And we have legislation for seat belts, helmets, and now social distancing is part of everybody's vocabulary. Theoretically, that could be related to primary prevention. And immunization has been long thought as a very specific item for primary prevention. And we know that the use of smallpox vaccination or polio vaccination has made a huge difference around the world. One thing about prevention, though, if it's successful, then we don't see a problem and people kind of forget about it or byplay it and so on. And I think that it's very important for us to be considering continuing immunization. And for example, everyone needs to get a flu shot shortly. But it's also touted that this is what could be the end of our pandemic if immunization were available. And that really remains to be seen, because we also have secondary prevention. And secondary prevention means that we detect a potential problem early and try and do something about it. For example, we know that individuals who have high blood pressure or hypertension and have treatment for that are less likely to get a stroke. But I'm also got immunization in the secondary prevention category, because, for example, there's a lot of information that influenza immunization doesn't necessarily 100% prevent you from getting influenza or the flu when it's coming around, but there is a lot of data that shows that people who have had influenza immunization are less likely to be hospitalized or die. And so there is some value in it. And finally, there's tertiary prevention, such as how can we soften the impact of a disease, such as dementia or frailty, particularly in residential long-term care. And to me, one of the critical things that we need to have for an intervention is adequate numbers of adequately trained and adequately paid personnel in residential long-term care. And this is something that I have been advocating for a long time, and it's very hard to move the needle in terms of making more of these things happen. And I'm hoping that this pandemic will really be increasing the activity and sympathy for really doing something about the situation in long-term care, residential long-term care particularly, but also in community long-term care. And training and numbers of people who are adequately paid is really crucial. Now, one thing is that things change as all of us get older. And if you look at younger people, more younger people are cognitively normal. More older people may be cognitively impaired, and age is the biggest risk factor for getting dementia. It's also the biggest risk factor for being frail. And an autopsy study was done of a group of people over 90 years of age, and there were over 1,000 people in the study. And when they looked at the brains under the microscope, Alzheimer disease in the neuropathological samples accounted for about half the cognitive decline. But Alzheimer's disease changes were not on their own in these people, and they had a number of other changes in their brains which could contribute to their dementia. And only 9% had pure Alzheimer's disease pathology. But in addition to this, they also looked at pre-death measures of frailty of these individuals. And they noticed that as people were more frail, the odds of them having Alzheimer's disease neuropathology decreased, but they could still have a dementia due to a number of other factors. So one of the things that we can do when we understand that frailty is a risk, particularly for people who are in residential long-term care and have a dementia, if we modify the situations that are contributing to their frailty and then thereby decrease the severity of the impact, or at least provide a tertiary prevention by decreasing the impact of the dementia itself. Frailty is a state of increased vulnerability resulting from age-associated decline in reserve and function. It's not necessarily synonymous with disability or comorbidity, but it is measurable. And we do know that physical activity and exercise, and we heard a relationship between frailty and changes in cognition. And there's a complex interaction of physical and mental health, changes in function, and social context. And we need to have directions, both clinical and policy directions, to help these people. Interventions targeting even one thing, for example, frailty or social vulnerability, may bring benefits for other factors, including the impact of dementia. And this, in fact, is one of the major themes of the Canadian Consortium on Neurodegeneration and Aging, which is a national research undertaking, and they're looking at just what could be changed here. And again, I'm coming back to COVID-19 and its huge impact across the country and in North America on residential long-term care, affecting older persons. And we know particularly there are frail older persons with dementia in residential care. There are preventive situations which were all, there's talk about pandemic fatigue. People are tired of learning or hearing about personal protective equipment, including masks, social distancing, hand washing, stay at home if you're sick, particularly if you're a family member or a staff member. And we can't lose sight of this. It's extremely important for us as we go forward, because they are issues. This disease can change the courses of so many people. And in residential long-term care in British Columbia, early in the pandemic, COVID-19 revealed the magnified significant systemic issues, and prompt attention was focused on care staff, including payment and preventing persons from working in more than one location. And ongoing review of the funding of residential long-term care and review for profit and not-for-profit operations with a look at responsibilities and accountability is very, very important. It's ongoing, and with any luck, we'll see some changes. There was a situation in Ontario that was reported in the Canadian Association of Retired Persons magazine, but we had heard about it in the news, and there was potential prevention of nursing home murders in Ontario because over 7 years a nurse gave insulin overdoses to at least 12 residents and 8 died. The question was, who failed to protect these vulnerable older people? And so a public inquiry was set up to help. And the question is, would it make a change? Would it prevent abuse and neglect? And this person was Elizabeth Wetlaufer, which has been publicized. And in 2017, Eileen Gillese oversaw public inquiry to investigate the events. There were 2 years accumulation of damning evidence, and she outlined 91 recommendations to address systemic failures. This was particularly focused for Ontario. It included stronger education and training, infrastructure changes, increase in numbers of registered staff, and addressing low staff pay. Just the issues that are extremely important. And unfortunately, the evidence that many of these recommendations were carried out was not present because there were so many problems in residential care. The other area that is really important, we noticed that limited social contact makes dementia worse. That makes dementia riskier. And family caregiver opportunities are so important. There's such an interdependence, and particularly again when we come to residential long-term care, but also it's similarly important in the community. And the dementia journey may offer avenues for reconciliation, healing, and joy. It's not all negative. Significantly missing from residential long-term care with COVID-19, this important social contact has been so limited and is even more profound when residents are dying. In other words, FaceTime is helpful, but it is not a hug. And when we think of all our relatives and friends who are in this situation, it is extremely difficult to manage on a day-to-day and cope with all of this. I'm glad we have social media and opportunities such as FaceTime or iPads, but it's just so in residential long-term care, and I think part of this applies to the community as well, but there's no substitute for adequate numbers of adequately trained and adequately paid staff in residential long-term care. And COVID-19 risk has affected family interactions significantly, and the critical social tertiary prevention has been so limited. So we have 12 modifiable risk factors for dementia, which have been identified. Dementia with loss of cognition, function, and interaction of frailty leads to increasing vulnerability. And prevention, clinical and policy strategies can be in place to mitigate the negative impact of dementia, even in the face of a scourge such as COVID-19. But it's very, very difficult in this situation.
I've looked at life from both sides now, from up and down, and still somehow with life's illusions I recall I really don't know life at all.
Thank you very much.